Good morning to all of you. You're very brave to be here at 8:30 on a Saturday morning. A few months back, I was at my 25th medical school reunion, and it gave me a chance to reflect back on what it felt like as I started my medical training. I remember a variety of emotions, but above all, it felt special. That feeling of being special was reinforced when our professors taught us very early on that medicine is indeed special because the public trusts us to be self-regulating. This concept had enormous appeal to me. Who other than our peers could possibly judge the quality of care that we're delivering? Certainly not the public. The belief that we're special helps clinicians do remarkable things, but when it comes to accountability after adverse events, that feeling of specialness in part has caused us to lose our way, and it's the primary reason that we struggle to really respond appropriately when care has gone wrong. And I think our inability to self-regulate is causing the profession to pay a very heavy price. We've come to see the public's trust as a birthright rather than something that the profession has to earn. But more importantly, we feel like we're immune from all the normal human reflexes that people experience when something goes wrong. And as a result, we really have failed at self-regulation. We aren't transparent when care has gone wrong. Our systems for learning from error are broken. And we look the other way when our colleagues are struggling with clinical or interpersonal skills. Well, there was a lot of optimism back 15 years ago when the Institute of Medicine released the landmark report to err is human. There was a lot of hope that we would make dramatic inroads on reducing medical error, but that really hasn't been the case. There have been some notable successes, but data from Medicare in 2010 suggests that adverse events are experienced by probably 13% or so of hospitalized Medicare patients. 1.5% experienced harm that it contributed to death. A full half of those adverse events were thought to be preventable. So not nearly the progress that we would have hoped when the Institute of Medicine report was released. And I would argue that the primary reason why we haven't made the progress that we would like is that we're not transparent. We're not transparent, and that makes it difficult for us to learn when care has gone wrong. Why are we not transparent? Well, it's normal and natural when something goes wrong for folks to want to keep that to themselves, to minimize, to rationalize. Think about how you respond personally when you've been involved in an error in either your professional or personal life. And that's made it very, very difficult to figure out how do we not only respond to the injured patient, but how do we learn when care has gone wrong. I was reading one of my favorite magazines recently, Elle magazine, and came across this particular story. The author experienced a serious medical error, and she asked the question, can a sincere "I'm sorry" make up for medical malpractice? She described what happened to her, and she said, in light of all of this, is Dr. P's apology still enough? Sometimes yes, often no. I think one of the big mistakes that we've made in the field is that we've been focusing far too much on what do we say to a patient when care has gone wrong. That's important, but that's only one small part of the puzzle. We need to be thinking much more broadly about what do we mean by accountability when care has gone wrong. The way we think about accountability is quite broad. It includes an environment where healthcare institutions and providers immediately report an adverse event to the organization and communicate about it effectively with the patient. They involve the patient in timely investigations. Think about that, right? How often do we ask the patient what they saw when care goes wrong, when in fact they're oftentimes the only person who was there from start to finish? We proactively reach out to make the patient whole financially. I can't tell you how important this proactivity is. Lots of organizations will say, oh, well, we provide compensation when we've harmed a patient by an error. But unless it's a clear-cut wrong site surgery or obvious error, oftentimes what they do is sit back and wait and see if the patient will request compensation. More often than not, the patient doesn't. It compounds the harm and the suffering. But in all of our research, what's come through loud and clear is that patients want learning. They want to make sure that we understand what happened, so it's less likely to happen from someone else. And as you'll see in a few minutes, this is actually the area where we struggle the most. But this has to happen in a healthcare delivery environment that remains patient-centered after injury occurs. Those normal reflexes we were just talking about lead us to sort of focus on the effect of the event on us, on the institution, on us as providers, and at a time when we should be the most patient-centered, when we've harmed a patient by the care that was intended to help them, we are, I would argue, the least patient-centered of everything we do. And that has to change. We need to do more than just respond to problems. We need to be proactively monitoring the quality of care. And when we encounter colleagues who are struggling to provide effective care, we step in and provide them with effective remediation. And then we not only learn internally, but we figure out how do we spread that learning to other organizations. And this all has to take place in a legal and regulatory environment that really supports this. This is what we ought to be doing when it comes to accountability. And from the looks on your faces, I can tell you worry that we're a long ways away from this particular vision. It really is a radical paradigm shift, moving in the area of event reporting to an approach that's immediate. Too often clinicians think, well, let's just sort of lay low for a little while and see if anything happens. Do I really need to make a big deal out of this? Communication with the patient and family needs to be transparent and ongoing. Even organizations that are experienced at doing event analysis, far too often at the end of the day, they conclude that the root cause was something the physician and the nurse did, and what we ought to do to improve it is to retrain them, rather than focusing on the system issues and human factors that were associated with the adverse event. We've talked about the importance of proactive financial resolution. When I've been involved in serious medical errors, my response has usually been to put my head down, think to myself, you know what happens, and move on to the next patient. And that, in retrospect, is not a productive way for clinicians to cope with the emotional turmoil that accompanies these events. Certainly it was not good for me, and I also don't think it was particularly good for the patient I was moving on to. And then patient and family involvement needs to be ongoing and extensive throughout, a paradigm shift in all sorts of ways. But as I said, this has not been a field that has been nearly as patient-centered as it ought to be. There have only been modest efforts up to this point to involve families as partners in understanding why errors have happened and how do we respond and resolve them. The reform debates in this area continue to primarily be driven by clinicians and insurers and institutions' concerns. And we actually have very little understanding of what accountability actually means to patients. Take the issue of financial compensation. Some patients feel if they've been harmed by a medical error, compensation is a prerequisite. Others, the offer of money to them is offensive. Why are you offering to pay me money in this particular situation? We understand very little of what patients and families want, but we know what the patient advocates are seeing. This was a story in the USA Today. Thousands of doctors practicing despite errors and misconduct. Thousands of doctors are able to continue practicing despite records of serious misconduct that puts patients at risk. Many of those doctors have had their clinical privileges restricted or taken away by hospitals, HMOs, and other healthcare institutions, but their state medical boards have taken no action against their license to practice. Consumers Union has what they call their Safe Patient Project, and a big part of that is doctor accountability. When your physician provides poor quality care, their patients are typically the last to know. Some physician backgrounds may be available in your state, but can you tell which ones have the most complaints, malpractice claims, or disciplinary actions? Knowing the background information on your doctor could save your life. Well, communication and resolution programs are an important development that seek to improve the way we respond when care has gone wrong. They started with pioneering programs at the VA in Lexington, Kentucky, and the University of Michigan. There was a proof of concept conducted at several institutions, including Illinois, Stanford, in Massachusetts, and in Oregon. We were involved, as were several other organizations, in large-scale demonstration projects to test communication and resolution programs. And the Agency for Healthcare Research and Quality has recently funded what they call the Candor Toolkit to try to really diffuse communication and resolution programs as widely as possible. The Candor process stands for Communication and Optimal Resolution. It's a principled, integrated, systematic approach that practitioners and institutions can use to respond to unexpected patient harm events in a timely and in a just way. The Candor process has several different elements to it. It starts with early event identification. The Candor system is activated. There's communication with the patient and family that's ongoing with an investigation, and it concludes in resolution. There are several key elements. One is what we call change readiness and gap analysis. Interestingly, when you go to most healthcare institutions today and talk about this, the first thing they say is, oh, well, we're already doing this. And if you dig down deeper, what you learn is they used this approach once last year with a case of a clear-cut medical error that everyone was aware of. And every other situation has been an exception for some reason. Well, we couldn't quite use this approach for the following reason, right? A gap analysis is basically, for those of you who are researchers, it's a series of key informant interviews with folks at an organization to really dig down and figure out, so where are you in each of these key elements? Adverse event reporting is key. You can't fix what you don't know about, coupled with really a human factors-based event analysis, open communication amongst all the parties after an adverse event, peer support, as I talked about, and lastly, proactive and fair offers of financial or non-financial compensation when the adverse event was caused by inappropriate care. Interestingly, for most of these programs, probably 3/4 of the events they handled turn out to be adverse events that were not preventable, but where good communication with the patient and family about what happened is still a critical element of what needs to take place. And a fair proportion of malpractice claims originate from adverse events that weren't due to error, where there's been a breakdown in communication, the patient and family sue because they can't find out otherwise what happened. Even organizations that turn out to be relatively conservative in the field of liability reform, like the American College of Surgeons, are starting to really embrace communication and resolution programs. When they recently listed the variety of different alternatives for tort reform, you can see on your far right, communication and resolution programs were the only approach that the College of Surgeons felt like really represented the most attractive reform solution, best encapsulating ACS principles of a just culture, while also restoring financial stability to the liability system. We've seen a number of organizations have remarkable success in this area. The University of Michigan, the average monthly rate of claims dropped. The median time to reporting to resolution decreased. Compensation costs decreased, as did legal expenses, and a similar a positive experience at the University of Illinois Chicago and at Stanford. Interestingly, you can see at the University of Illinois, adverse event reporting almost tripled. And that's a good thing. That means clinicians are actually feeling like they can come forward and talk about adverse events in a way where they won't be punished for their mistakes and where there will be learning. But what do we know about how these conversations are actually going? Norm told you in detail yesterday about how hard it can be to tell the truth. I've been talking about these normal human reflexes that we all experience that kick in and want to lead us to keep information to ourselves. Well, we've been studying how are these conversations actually going. And together with Copic, who's a large malpractice insurer in Colorado, after adverse events, we've actually been giving out surveys to patients and to doctors, asking them to rate the quality of the disclosure conversation. This is data from a little over 800 events. About half of the patients return their survey. Nearly 3/4 of the doctors return their survey. If you can get 3/4 of physicians to do anything, you'll realize that this is a good response rate. And we've continued with this work and see physician response rates nearing 80%. It just shows you how engaged clinicians are in wanting to understand how they're doing with these conversations and how to make them better. Well, one of the things you see right off the bat, and remember this is a survey where the doctor and patient were talking about the same event. A third of the patients thought the severity of the event was extremely serious. I might have died. Only 7% of the physicians rated the severity of the event that high. We're starting off these conversations really on pretty different pages about how bad the event was. Then we asked both the doctor and the patient, just on a 0 to 10 scale, to rate the overall quality of the disclosure. 0 being very low quality, 10 being very high quality. Here's what the physicians think. We give ourselves A+, 8s, 9s, and 10s. Disclosure is going awesome, right? And the patients are really not so sure. Some of the patients felt like the disclosure went well. But look, half of the sample rates the quality of the disclosure as a 5 or less. And physicians were largely clueless that some of the conversations from the patient's perspective had gone that poorly. Some of the masterful communicators in this area are the ones who are actually able to remain patient-centered throughout, which means recognizing when the conversation is going poorly, pausing and figuring out how to adapt. Much more commonly, what we see is clinicians are so wrapped up in their own distress and trying to figure out how do I just get through this discussion that it doesn't really matter what the patient is saying or doing. They're just trying to get the words out and then hope their pager goes off so that they can leave the room. And then when you ask patients to rate the quality of specific skills that the doctor used, you see about 2/3 of the time the patient thought they got a sincere apology, good listening skills, doctor was truthful. That's good. I mean, we'd like to see those numbers much closer to 100%. But look all the way down at the bottom. Only 1/3 of the time the patient got any sort of assurance about preventing recurrence. It's something that, as we've said, really matters a lot to them. At your organizations, are you doing anything to systematically measure are disclosures happening when they should? And if so, how well are they going? My guess is probably not. Which is interesting because every other area of quality and safety, we rely on metrics for improvement. So why in the world are we not more commonly tracking how well these conversations are going with patients and their families. It's a little bit like, the clinician who worries about asking the patient if they're suicidal, lest somehow it prompt the patient to say, well, now that you mention it, this actually sounds like a good idea. There's been concern that if we reach out to patients and ask them, how did that conversation go for you? They'll say, now that I think about it, that was really bad, and I'm pissed off and I'm going to sue you, right? Which is just sort of ludicrous on its face. But in an area where people are feeling very risk averse, the notion of reaching out to them and asking about how this went is very scary. This is an area where, as bioethicists, I think we have an important contribution to make, because I do think there's a real challenge around timing. When is the appropriate time in sort of the experience of grieving after an adverse event to reach out to them and ask about this type of data? But at the moment, since few organizations are doing it at all, we have to cross that particular hurdle first. In the pediatric realm, you experience a variety of unique challenges. Obviously, the stakes are very high. The impact of harm can last for years and years and years, and the impact of it can be uncertain. There's a whole different complex dynamic when the disclosure is to the parents, or perhaps it should be to some extent to the child, and how do we negotiate that? Fortunately, John Lantos and others have written a lot of great stuff about informed consent, and a lot of that applies directly to this issue of communicating about adverse events. When should we talk directly to a pediatric patient about an error in their care, and how do we do that in a way that's most effective? We've done a fair amount of work in the area of birth injury, and I'll tell you, this is disclosure on steroids. Not only are they all the issues that we just mentioned, an incredibly high emotional tone, but then there's the complex interplay between the obstetrician and the pediatrician in trying to sort of figure out what happened and how do we share this information in a coordinated way with the patient and family. So where do we stand now? I would argue that we have lost the public's trust in our ability to self-regulate. And to regain that trust is going to require the profession to take some pretty bitter medicine, mostly in the form of transparency. We're going to need to get much more comfortable essentially airing our dirty laundry, not only with the patient, but with the public generally. That's going to be what it takes for the public to begin to trust that the process for self-regulation can work the way we would like it to. There's a lot of interest in communication and resolution programs and their transformative potential, but our experience with implementation so far has been mixed. A lot of organizations are emphasizing the communication part, are still very nervous about dipping their toes in the water around financial resolution. And for my fellow researchers in the audience, I hope you will join us and help to strengthen the evidence base. Even though these are programs that are fundamentally about quality and patient safety, most of the evidence from places like Michigan, Illinois, and others is about the impact on liability. And that's fundamentally not what these programs is about. What do we need? We need trusted sources of best practice and training. We need this patient-centered vision of accountability, a much stronger evidence base. We're working on incentives. We want organizations that do an outstanding job of communicating with patients and families when something has gone wrong, or that have set up exemplary programs in this area to be rewarded in some way. And I'll tell you a little bit about one of those programs in just a minute. This is an area where I think we're just at the beginning of the beginning, and there's enormous enormous room for innovation. And lastly, even though this has worked at individual institutions regardless of the state or federal policy environment, there are some very vexing state and federal policy issues that we need to address. For example, the National Practitioner Data Bank is a great concern to many clinicians because anytime there's a payment made on behalf of that doctor, it's required to be reported to the data bank. The doctors see it as a horrible black mark and aren't willing to participate in these programs. We need much better ways of tracking clinicians who are providing low-quality care and thinking through what does the next generation of the data bank look like. Well, you know, I talked about the normal human reflexes we all experience, and not only is there that normal impulse to keep things to ourselves, it's normal for both patients and, I would argue, for clinicians to blame. And this is making it hard to move forward with the culture of safety that's required for this field to succeed. Lucian Leape said a long time ago, the single greatest impediment to error prevention in the medical injury is that we punish people for making mistakes. James Reason said something similar. Fallibility is part of the human condition. We cannot change the human condition, but we can change the conditions under which people work. Lots of clinicians think when it comes to blame, it must be coming from outside the profession, regulators, the tort system. I would actually argue that far more blame comes from within the profession. Why do we blame one another when care has gone wrong? Fundamentally, I think blame feels good, especially since so many of these errors represent situations where competent providers have stepped into a system that's broken, where it just as easily could have been us, right, who was the one who was on the sharp end of that error. And it makes us feel better to think, oh, I wouldn't have done that. That couldn't have been me, right? Thinking about our role in promoting a culture of blame is important if we're going to make progress in this area. Lots of you are familiar with the concept of just culture. It tries to find that middle ground between a punitive shame and blame approach. And for a little while, we were in a blame-free mode, which no one really ever embraced. Clinicians want to be accountable for their role in adverse events. So just culture tries to seek that middle ground. It tries to distinguish between human error, where the appropriate response is to console, at-risk behavior, where the appropriate response is to coach. I certainly engaged in at-risk behavior this morning on the way to the conference because I don't think I was driving at the speed limit. Anytime we don't obey sort of known safe practices, it's at-risk behavior. Vast majority of time, it doesn't cause any problems whatsoever. But when you take at-risk behavior and couple it with a defective system, that's a recipe for problems. The appropriate response, though, to at-risk behavior is not to punish, but it's to coach. And I'm sorry to say that there are some situations where clinicians behave recklessly. It's far less common than patient advocates would have you believe, but it does happen. As I've worked with the Board of Medicine in Washington and other states, some of what you read about what clinicians has done just would curl your hair. You think to yourself, how in the world could a clinician do that? Just culture calls for punishment in those situations where clinicians knowingly ignore safe practices. But fortunately, those are the exception. Just culture has been conceptually appealing, but incredibly hard to implement. AHRQ does a large national survey of safety culture, and in their most recent survey, 500,000 healthcare workers, still half of them said they worry that their mistakes are going to be held against them. What's going on there, right? 15 years since To Err is Human, why do we still have 50% of healthcare workers saying they worry about mistakes being held against them? That just provides fuel to these normal reflexes of wanting to keep things to ourselves, wanting to minimize, wanting to shame and blame others. We've been working more and more with regulators to try to figure out how can we create an environment that's supportive of this work. I don't quite know. It was one of the most unfortunate acronyms that I'm aware of, but our Board of Medicine is the Medical Quality Assurance Commission, MQAC. Why you would have a Board of Medicine with quack in their name is beyond me, but they've been a wonderful, wonderful partner in this work. we've been working on what we call the CRP certification pilot. We're working on aligning their internal policies with Just Culture and starting to think about what rules and legislation would help support the work in this area. CRP certification we don't have a chance to talk about, but it's basically for organizations that have used the CRP approach to respond to an adverse event. We've pulled together a neutral review panel that will certify whether this was handled appropriately. If so, our Board of Medicine has agreed that they will close those cases as satisfactorily resolved without disciplining the provider. That's an incentive, right? To be able to tell a doctor, if you participate in this process in good faith, it will shield you essentially from punitive action from the Board of Medicine. Then you've got the doctor's attention. And then lastly, I'm leading a collaborative across the country that's trying to pull together communication and resolution programs and others to really figure out how do we take this concept of accountability and learning after medical injury and go from that vision to the reality. To do so is going to require a lot of things. We have to look inside ourselves and understand those normal human reflexes. We are special in lots of ways, but we experience those impulses just like everyone else does. We need to understand how to manage those and really participate in communication and resolution programs. And we need to build programs for responding to adverse events that not only meet the needs of the injured patient, but that the public and public advocates can look at and trust. Thank you.